So welcome to another episode of Voices in Health and Wellness. This is the podcast where we sit down with health and wellness innovators who are redefining what care looks like. I'm your host, Dr. Andrew Greenland, and today's guest is someone whose work truly sits at the cutting edge of what's possible in mental health care. Dr. Saraya Rahman is a board-certified paediatric hospitalist, the medical director of her own integrative practice, and a co-founder of IACAP, a community and consultation group pioneering the use of ketamine-assisted psychotherapy for adolescents. So with that, so I'd like to welcome you to the show and thank you so much for joining me today.
Thank you. And I will just correct that it's actually IACAP, AYAKAP.
Okay.
So
I will correct that. So thank you very much for clarifying. So could we start a little bit with your journey and how you moved from being a pediatric hospitalist into this integrative and now psychedelic focused work?
Yeah. As one of my friends says, you can't get here from there. There's no clear one path, clear path through. However, I think as a physician, lifelong learning is always the way through. Looking at the problems that are in front of us, seeing more deeply into the solutions that are there for the problems that may be in plain sight, but may be underutilized. And then bringing in the experiential aspect of being a physician. A physician's journey is lifelong. It's a different profession from any other, and it continues to evolve. So, both my parents were physicians, and growing up, I saw that it's who you are. It's a perspective that you walk into the world, and people, really trust a physician to be the one that says, yeah, there's something wrong here, and yes, we can do something about it. And so all that has always been kind of the motivating factor behind stepping into, for example, hospitalist medicine itself. Pediatric outpatient is where I started. And then I went into hospitalist medicine because I wanted to work with the higher acuity kids, the kids that had more chronic illnesses. And I saw a lot of trauma. So I think that trauma-informed lens really helped to understand that we are under-treating mental health conditions in pediatrics specifically. We just don't have the resources. In the United States, at least, we have a lot of patients who end up in the emergency room, sometimes for days, awaiting placement, because the only higher level of care that we can provide is, hospitalization, and we just don't have enough beds to actually deal with the number of patients that are coming through. So one of the kind of realizations as I was training in moderate sedation, so for about the last 10 years in a trauma center, I've been providing moderate sedation services, just like an anesthesiologist would, but it was being handed over to the pediatric hospitalist, because the studies show that we can do just as good and just as safe of a job because we know our patients better too, and we're much more aligned with the pediatric physiology. So using it for painful procedures, long procedures, and becoming familiar with the medication that's ketamine, right? And at that time, before the pandemic, I really didn't have a consciousness about ketamine and psychedelics. None of us are taught about that. We're just taught that there's a emergence reaction that occurs mainly in adults after you've given them ketamine for a painful procedure, and that's just something that we can chemically or physically restrain for, not understanding that there's an internal experience happening, and that what happens on the outside, the set and setting, how a person is prepared for that experience can really make the difference. And so it really was kind of like a penny drop moment where it was like, wow, this is real. This is, this ketamine is a very ubiquitous medication in the emergency room and in the inpatient and the procedural suite. However, it took me 2 years to really convince myself that this is a real psychedelic, and that psychedelic medicine in and of itself is creating a different paradigm for mental health. So those two things really drove, I think, the impetus to change lanes and to do so over the last 3 to 4 years. Yeah.
And what was what sparked the pivot to start using ketamine with adolescents specifically?
Yeah. I was just in a meeting of our group, IACAP, which is the Adolescent and Young Adult Ketamine-Assisted Psychotherapy group we started about 2.5 years ago. And we are physicians and psychotherapists and other professionals who meet around this exact question. It's like, okay, so if we say that, in the adults, we're seeing a lot of results with treatment-resistant depression, with PTSD, with anxiety, with eating disorders and OCD. How does this now relate into the adolescent population? What do we have to be aware of? What are some of the pitfalls? What are the best practices? So even just thinking about it in that way has revealed to us that there is a population of patients for whom the risk-benefit analysis makes sense. As in, you have a patient who's catatonic and in the hospital for 100 days. Just this morning, a physician was giving me that story. I mean, we're hospitalists, so we see these patients every single day. We try everything. It's a multidisciplinary effort. It's a lifelong trajectory for this patient. And they were talking about how they used ketamine in a lumbar puncture situation. So they needed to see if this patient had high, pressure around their brain and spinal cord, and they used ketamine as a medication to just sedate during that procedure. And what they noticed is that over the next 3 to 4 days, the catatonia disappeared. The patient started to be more verbal, actually remembered the doctor's name, had never spoken before. The whole team was just astounded. And at the time, they didn't know what to attribute it to. There was not even a question of, could this have been the ketamine? And now 3 to 4 years later, as we're looking back at some of our most difficult cases, we see that there's a cohort of patients who do suffer with long-term treatment-resistant conditions, for example, OCD, eating disorders that can absolutely create a high degree of morbidity as well as mortality. And to have a medication that's kind of ubiquitous, well-known, used for the last 60 to 70 years, has an amazing safety profile. We can use it down to neonates, but also comes with this kind of cultural stigma that's been attached to it, has been a really interesting dilemma. And that's why our group exists, to parse that through. It's like, who are the patients for whom this is a good idea? Another example is patients who have had treatment-resistant depression, for example, and maybe on 3 to 4 to 5 medications. That is a very common scenario in adolescent depression. And so using a rapid antidepressant like ketamine, not all the time, as an intensification induction, and then as a maintenance phase, we can really think of it as a procedural, interventional, mental health treatment that can allow better functionality, decreased medication use, improved, developmental milestones. That's the other piece that's really important when we talk about adolescence, is we're not just talking about the mental health diagnosis. We're talking about an entire lifetime of low functionality, which may reflect in their relationships, in their, ability to learn, to hold down a job. And so, I think this is a real under recognized gap. And so we're really excited to talk about it, to bring more people to understand that, yes, there may be caveats and all of that, but the bang for your buck that you get is pretty astounding. And that's the piece that I think comes with psychedelics, and that potential for transformation that we see.
Amazing. Can you even remember the very first time you used it in this context? Was it that sort of that first patient that really made you think, okay, there's really something in this?
Oh my gosh. So here I was, scratching my head going, nobody's going to allow me to do this within the hospital situation. I'm going to break into private practice. And, I really took that seriously. I was like, all right, I'm putting myself out there as this pediatrician. And it was kind of like all right, I'll just put out an intention and see what occurs. And I think I might have mentioned this to you. I applied to, I was like, okay, there's a conference coming in about 18 months. It's in my consciousness. If I do have a patient, I would love to presented there. And lo and behold, there was a patient who reached out to me, a parent, and as we kind of proceeded through the intake, it was positive. It made sense. They were really motivated. They had already experienced psychedelic healing, and so they were a really good container for this. And so there was a certain sense of, okay, we're doing this and we're trusting the relationship, the therapeutic relationship that's building here. I did a lot of psychoeducation. I did a lot of consenting around, this is a non-ordinary state of consciousness. We're not here, we were very clear about what we're here to do and what we're not here to do, a lot of harm reduction as well. And it was really challenging. It was challenging in the way that it's not just the medication, it's not the medicine. The medicine opens a door, and in each opening, there's an opportunity. There's an opportunity that arises, whether in a memory that is clear and is coming up for, exploration or relating. There's an opportunity for withstanding the kind of difficulty or discomfort that may come with really disturbing OCD thoughts. In this case, specifically, it was thoughts of pedophilia, that can occur, and suicidal thoughts, thoughts of ending their life. And kind of really the opportunity is to understand your thoughts, so I really leaned heavily on my knowledge and practice of meditation, contemplative practices, narrative medicine, yoga, somatic breathwork, all of that, just to bring, the nervous system regulation is part and parcel of this treatment. So it is, what I learned was it's very intensive. It needs a lot of support. It needs a lot of regularity, and it takes time. It actually takes a much longer timeline than what people might be reading about. The popular press might be talking about, well, yeah, you do 6 sessions and you're a different person and it's transformational. And for some people, yes, that it can be that transformational. But what the stories aren't revealing is that that person did a lot of work beforehand that was an investment into what became available in this transformational field. So it is not one size fits all. It's really contextual. It has an opening and a availability, but it is absolutely wonderful to see those assessments, the PHQ-9, the GAD-7, the PCL, so depression, anxiety, PTSD scores going down and staying down. And the opportunity that brings out, if you're feeling better every day, you're feeling a little bit more of your motivation, that's the opportunity for coaching that we get to engage in, which is, okay, you're feeling better. What do you want to do with this extra energy that's showing up for you that you've really not been able to access? And then how do we hold that? How do we let the person actually, one of the biggest, I think, feedback, one of the biggest pieces of feedback I got from the parents was, we're afraid to breathe. We don't know if this is going to stay. When the changes first started to show up, they couldn't believe it. It was kind of like is this a new reality we're stepping into? Can we trust it? Is this going to go away? Like the patient themselves had a lot of, anxiety about, okay, now I'm better. But just like any other time I felt better because of psychotherapy or medications, is this also going to go away? And so really getting the person to recognize, look at the pattern. So I do a lot of actually looking at the objective data, and it's fantastic. After 6 weeks or so, you'll, and I'm talking about now my adult patients, after 6 weeks or so, they'll come back and their story may be, yeah, it worked, but I'm still not feeling, better. And then you show them the objective data. They're like, oh, I didn't know, so we use a lot of trackers, sleep trackers, mood trackers, heart rate variability trackers. Hypertension goes down. That's one of the interesting things I see. Ketamine is such an interesting medicine. If a patient comes with anxiety, they've got high blood pressure. They're on a medication for high blood pressure. 4 to 6 weeks later, we've done some ketamine treatments. Their stress and their anxiety levels are down. Their blood pressures are normalizing, and sometimes they actually have to wean off of some of their blood pressure medication. So that's also an interesting phenomenon we see. So really just getting at the root cause of some of these things has been really interesting.
Thank you. And what were some of the early responses you got from colleagues and parents when you started exploring this space?
Oh, goodness. Yeah, absolutely. I call it my coming out. Coming out of the psychedelic closet. We all joke about it. There's a great number of neuroscientists and physicians and therapists who are all going through this process that I remember going through in 2022. I was burning out. I was in a pediatric trauma center. I was really realizing that I had to heal myself or so there was this personal impetus. And I think that is probably the most common reason why people become involved or see this kind of healing, because it's affected them or somebody else around them in a very transformative manner. And so we see this again and again is when you have experienced it, you kind of become a believer in it because it's the evidence of your eyes. And so there was this kind of like, yes, this is the truth and this is real, but I'm taking on a lot of career jeopardy. I don't know how this is going to end. Am I going to be known as the ketamine pediatrician? And always it was, and it was like a dual world perspective, because I would go for my trainings. I would go to places like Berkeley and Colorado for my psychedelic training, and within that community there would be like this welcoming of like, oh my gosh, thank you, we need more pediatricians. We really need to address this childhood epidemic, childhood abuse that's underlying. We're talking about complex PTSD that masks as a major depressive disorder, and we try medications and psychotherapy, but you can't get at the nonverbal trauma. With psychotherapy, you can only get at the verbal. You can't really get at the developmental and some of the relational trauma that happens in childhood, and complex PTSD. And so I see that. And then in my, pediatric, world, I've really tried. I've given grand rounds. I've presented at the American Academy of Child and Adolescent Psychiatry. And within those spaces, what you'll see is that the general, kind of leadership will be very skeptical because they'll be carrying attitudes that are more kind of from the, boomer generation and Gen X attitudes. And then there'll be a younger cohort of physician scientists and therapists and ED physicians, who are, looking at the crisis that's in their emergency rooms, and they're like, oh my gosh, tell me more. How do I do this better? So it's really a dichotomy that we're facing here. And it's a range of attitudes. So I've learned that, not to take it personally, to be more grounded. And I think the community aspect has really helped. Is we talk to the parents, as psychedelics become more mainline, there's also a awareness amongst parents. There's in the United States, at least, for example, nonprofits like Moms on Mushrooms talk about how microdosing, psilocybin safely has helped them be more emotionally focused on their children. Doing their own trauma healing has actually helped them to be better parents in a lot of these, intentional ways. So I'm also aware that as a pediatrician, and pediatrics, we're especially integrative pediatrics, the pediatrics that's kind of practiced within the context of the family, their intergenerational trauma, their trauma burden overall, the awareness that family systems can really respond to the trauma unconsciously, in the scapegoating, in the narcissistic kind of patterns of relationships. And so we're becoming aware, I think, as pediatric professionals, of how trauma is working in the family systems around the patients that we take care of. For example, now if I see a patient with anxiety, I know for a fact that it's 100% within the family system. And so we don't really do that work. We don't really turn to the parents and say, how are you dealing with what's going on? How is your anxiety? And do you realize that you are one nervous system when you're with your child, and that matters? And how can we, so really turning that lens of integrative practice has really helped as well.
Thank you. So there's definitely a growing attention on the mental health crisis amongst adolescents. Can you speak to that, and can you sort of see how ketamine-assisted therapy might fit into that wider conversation?
Oh, what a big conversation. I mean, we're talking about a time, we're in the context of our time right now. Great transformation, disruption, disaster, violence in the United States is an uptick. I mean, I'm a parent of 2 teenage young adult kids, and I remember the times where I would, have to drop them off to school, having just heard about a school shooting that happened maybe, 2 counties down, right? So that's the reality of a child's life in some countries, and so what we're seeing in the pediatric population is an uptick in, when a child goes to school and the school is not supportive of who they are and what they're, what they need. The bullying, we're talking about bullying. We're talking about not being met. We're talking about this cohort of students who really mask, who really just kind of tolerate what their life is, and it comes out in different ways. So we're within that, and then you talk about the climate crisis. We're talking about a food supply system that is more processed than non-processed, and I'm talking about when you look at the general population. If we look at very resourced kids, they have a different set of problems that do also come out in mental health disorders. But if we're talking about the general population, our air quality, our water quality, the quality of our food, the quality of, it all kind of comes into the picture for how, let's say, a mental health condition can really become ingrained, become identity, this is who I am now. Instead of this is what's happening to me, right? And only later as adults, when we have safety and we have that mature way of looking at things, can we kind of look back and recognize like, oh, wow, that wasn't me. That was what was happening around me. And that was the label given to it. Or I couldn't even have language for what was happening to me. A lot of childhood trauma is kind of just pre-verbal, as we talked about. And so when we talk about adolescent mental health, we're talking about the future adult mental health crisis. We're talking about the roots of what's happening to everybody. And so the way it shows up here is in a higher degree of disability applications that are happening within younger groups. So more and more young people are actually applying for more disability. So there's that trend that we're seeing. We're seeing a greater awareness maybe and diagnosis of neurodivergence and autism in adults, and this concept of masked autism, so neurodivergent adults who have higher than normal intelligence and never really fit in, and basically developed a way of relating to reality that was very much about not being their authentic self, and how a lifetime of doing that can really lead to a sense of disconnection, and all the things that follow from disconnection, right? Depression, anxiety, addiction, and things like that. So we are learning that the adolescent mental health crisis has a trauma aspect, has a neurodivergence aspect, has kind of like we're feeling disconnected from our bodies. We're feeling disconnected from nature. We're feeling disconnected from our role on this planet as human beings. Like when you talk about neurodivergent young adults, they have a high sense of justice. They have a high sense of truth telling, which can be really problematic in polite society. Nobody wants to hear it, and so we kind of take the population that may be the canary in the coal mine in a situation, and we go ahead and then shut them out. And maybe those are the voices we actually need to hear more and bring into awareness more, because I think what they're calling us back to is a reorientation of our relationship to being human. I think we really are at this kind of, and I think that's where it fits into the overall, piece of psychedelics, because what psychedelics have been shown to do, like across the board, any psychedelic you talk about, is it increases people's awareness of their nature relatedness. So there's kind of like a burgeoning, like an uncapping of our ability to connect with nature, to feel like we're part of nature, and actually be healed in that kind of very elemental way by the patterns of nature. So one of the things that we talk about after psychedelics is, go and integrate, meaning go feel like yourself out in nature, and just that feeling of, even and what we're talking about are the diseases of the ego, right? We're talking about when we feel, when we become so entrenched in the idea that we're better, or we're superior to what we're embedded in, and then we can maybe have a little bit of a reset as to our proportionality. It's like when you look at a 500-year-old redwood and you really look at it and you really feel with it, and you see the majesty and the impact of it and just what it represents. And then you see the forest fires that are taking them away. The sense of just despair that we feel right now, that is one of the kind of probably the dangers of psychedelics, I would say, is that you start to feel too much. You start to feel it all. And if we don't have a community, if we don't have language, if we don't have a framing, if we don't have trusted, understanding of like, okay, why am I so dysregulated? I did psychedelics. I thought it was supposed to solve everything. It's like, actually what it's solving is maybe our disconnection, and actually getting connected with where we're at can be disruptive to the patterns that we've been used to. On my treatment-resistant disorder diagnosis patients, one of the first things they say as they're starting to feel better is that I feel a lot of grief. I feel better, but I feel a lot of grief. And what is that grief? It's like, oh, I spent a whole lifetime not knowing that I could connect, that this was possible, that I'm not meant to be this. I am actually more than what I've been led to believe. And so there's 70-year-olds mourning a lifetime of living with diagnoses they didn't have to. So I think we're going to see more and more of that as psychedelics become more mainstream. More and more compounds are coming out that are going to be easier to administer. I mean, at this point in time, it's a bit of a wild west. When you talk about dosing, there's no way of ensuring that you're doing any kind of dosing that's weight-based or person-based. You're kind of like doing it and see what happens, whereas I think with ketamine, we have a lot more of that piece sorted out. We have, decades of data on how to dose well, what's a low dose, what's a medium dose, what's a high dose, a lot of different ways to administer it, and so to do it safely. So it's a really interesting place to be at the tension of these two things. The psychedelics are really coming online, but they're really coarse, and they may not be ready yet for another few years or so. And the practices that are there are going to be really constrained and kind of very basic and coarse. And then you have, just the ketamine, which we're a lot more familiar with as the emergency room physicians and hospitalists, and to know that there's a benefit to it. There's a benefit to it, that waiting on the classic psychedelics to hit the market, we're possibly leaving a 10-year gap in some people's lives of treatment. So that's on my mind too.
Great insights. Thank you for that. So you're building a network that spans North America, South Central America, and Australia. What's different about how this work is being adopted internationally?
Great question. We just had a wonderful check-in with our Australian counterpart, one of the therapists who has a treatment facility for eating disorders. And they've been in their rollout for about 2 to 3 years now in Australia. And it was just fascinating to hear how different it is. They have a much more clinical, protocol. There's not a lot of this Wild West underground that they're involved in. They're able to use MDMA, psilocybin, and ketamine in treatment centers for eating disorders in the above 18 age group. And one of, so that's how that's working. In South America. I'd say that there's a greater emphasis on ayahuasca and psilocybin, just because of the familiarity and the constructs there. And I think South and Central America definitely have their own culturally, aligned ways of doing medicine. And what you'll see is it's kind of like the medical model and the indigenous model, and the variations that are kind of at the intersection of the two. So the medical model, very much based on patient selection. Criteria that are being used are patients who are very well, into their psychotherapy, journey, are resistant to standard treatment, and then have the ability to engage in a very rigid, protocolized way of doing it, and they're following the MAPS protocol. So if anybody is curious about what the protocols are around it, MAPS, which is the Multidisciplinary Association of Psychedelic Studies, based here in the United States, has trained the large number of the MDMA therapists worldwide. And I know that they're working in other places like the Middle East. They've actually done work in between Israel and Palestine as well. So really focusing on these conflict areas. And in North America, actually, the VA, the Department of Defense, a lot of work is being done in PTSD, in the veteran population, because in the veteran population, you have such a high degree of recidivism, and chronic, functional impairment, that the VA has really understood that ketamine therapy is a really good tool that can be used, and now they're actually paying for clinics that cover that. So there's a wide range. It really depends on who's pushing for which population. So the vets are definitely having an opening happening around, for example, ibogaine as well. Texas and other states are funding ibogaine treatment. Ibogaine is a psychedelic that comes out of West Africa, out of Gabon, based on the iboga plant. And so that is a very powerful psychedelic. So I'll kind of end with saying, when you're thinking about psychedelics, it helps to think about length of action, duration of action, because that actually correlates to that critical period that's open of increased neuroplasticity and flexibility. And so ketamine is the one that has about 48 hours of neuroplasticity and flexibility, because its duration of action is about 1 to 2 hours if you use it psychedelically. And then ibogaine has the longest duration of neuroplasticity, so its impacts last for weeks. And so it's being investigated in not just PTSD, but also traumatic brain injury, spinal cord issues, just things where we're trying to rehabilitate actual neuronal growth, is a fascinating place. So all that to say that there is quite a difference in uptake based on the culture of the place, the context, the populations that are being made more aware and are advocating and actually finding their own funding. At the end of the day, it's who wants to fund what. For example, in San Diego, we just had a protocol that had been approved, and to use ketamine-assisted psychotherapy in youth in a kind of halfway house situation where they would be there for 3 to 4 weeks, and it was initially approved and now has been the approval has been taken away. So we're really the barriers that are there, some are visible and some are not. And so we're just trying to work within these paradigms, but it's really wonderful to have an international global awareness, because trauma is global. Trauma is happening in all these different ways.
Thank you. I was going to ask you, are we ready clinically and culturally for this kind of model of care? I guess your answer will be yes, but I'll ask you anyway.
Actually, the it's more nuanced. Absolutely, it's very much more nuanced. I feel like, I will admit to the fact that the deeper one goes into the psychedelic world, the more distorted our lens becomes. So, I would say I would couch that with, when I'm in Colorado and I'm talking to a physician who is working with psilocybin and ketamine and seeing things, I feel like I'm in the future. It's been done in a really beautiful way. But I'm also really aware that, there's always this narrative, especially in the United States, of the quick fix, of the thing that's going to solve everything, and the ways in which our culture responds to the idea of the quick fix, of rapid adoption, but not really in the way that would lead to good clinical outcomes. And so I think that's where my caution lies, is that it's not for everybody. What we're learning is it's really about preparation. It's really about the trust in the relational aspect of the healing, meaning, is this therapist that you're working with, or this container that you're working with, really able to hold the kind of experience that you might end up having? So it's a very experiential container, meaning that we got to know what's there, and sometimes we don't, and we still have to kind of, we might find ourselves in the middle of a treatment protocol going, wow, this is new information we did not have, and even this person didn't have. So I'm reminded of the Johari window, the things that you know, and the things that you don't know. And sometimes for some people, that window of I don't know what I don't know can be that's the box we open. And so if we end up opening that box and we don't have the relational container, if we don't have safety, what have we just done? But re-traumatized, but made somebody feel alone again. Disconnection and loneliness is is the hallmark of mental illness. And so if we can keep our sights on what is it that we're really doing with psychedelics, what became clear to me is it is about, the container, the community. So the ways that we've kind of worked with that is, I think clinics like ours have understood that we're here not just to be a medical clinic. We're actually here to provide the structure and the healing resources. And that may be a yoga class, that may be breath work, that may be regular events where people can just connect with other people who are going through the similar things, similar aspects of this healing journey, and to really feel that heals. So I would say the culture is ready in some places. It's very well developed in Silicon Valley. However, as we know, Silicon Valley can be like the jet fuel to anything, right? And so what we're seeing is also distortions of culture, distortions of, I think, there's a story within our human condition that's about, I'm broken, I'm beyond help, and I need to be fixed, right? That's one story. And I love how, physicians like Gabor Mate, and others talk about, actually, you are experiencing the result of what happened to you, whether you were a child, whether you're adolescent, whether you were an adult. And if we can think of it that way, we really source a lot of compassion, a lot of awareness, a lot of forgiveness, which is really at the, kind of basis of healing, true healing, and acceptance and moving on, so people are able to, and this is where the other piece that we work with is narrative, healing, which is, here's the story that needs me to be this broken person in the midst of this story. And I've been telling it to myself for so long, and other people have told it to me for so long, that it's become what I live. I don't even know what's outside of it. And slowly over time, this awareness that that was a story, but I could rewrite the parts of the story that aren't functioning, that aren't actually real, that aren't actually honest, or authentic. And what does that look like is a much larger, I think, time intensive, moment. And I think if we can, as a culture, connect with each other in that way, I think what we might be talking about is culture change. And a lot of people talk about that in the psychedelic world is with greater awareness, we're really changing the paradigms of psychiatry, and that's, I can't speak to that. I'll let somebody much more erudite and learned in the psychiatric fields talk about that. I go back to the father of psychiatry, William James, who, did nitrous oxide in the early 1900s, and talked about the varieties of experience that lie just beyond our awareness, and how if we are to have a complete psychiatry, we can't leave those out. So I'll just end with, kind of that awareness that psychiatry itself is a young profession, and human beings as well are a young species.
So what does your typical week look like at the moment? You do various things. You're involved in clinical care and education advocacy. Yeah. Just give us some sense of what a typical week looks like for you. I'm guessing no week is typical, but
typical week, I'm a mother. As part of my own healing, it was really important to me to pay attention to what my own physiology and my nervous system needs, because this work is really taxing. It's emotionally taxing. You have to be present completely. It's not just head work, it's actually heart work, and we get really involved. So being aware that this is a very different pace of work. So I may see up to 2 to 4 patients a day, and that's about it. And that would be the max, it would be for one individual person who's in the room for 2 hours at a time, really supporting a patient through the situation, through their treatment plan. There's a lot of phone calls. There's a lot of talking to psychiatrists, therapists, medical evaluations, preparation. We do a lot of integration. So between getting people ready to go into this into the space, making sure that they are keeping in track with their integration. There's a lot of checking in, and a lot of making sure that we're getting the objective data. I really believe in the qualitative piece of it. So I'm taking copious notes about what's happening in the session, what's happening afterwards, what are some words and phrases that people are using, because sometimes that is the piece that really turns, turns the kind of key in how this healing is going on, is what really happened, what came through, and what do you need to make meaning of. So it's a lot of real intensive, and I love that. I love looking at subtext. I love looking at language, and what that is. So it's kind of like I joke that I came into medicine, went into pediatrics, really went into medical education, and I think psychedelics are also a learning tool. Went into narrative medicine, and now all of that is here in like a practical, kind of therapeutic way. So typically these are long days. I'm doing a lot of social media. I'm doing a lot of talking, educating, talking to therapists who might be reaching out going, hey, I've got a patient who's doing ketamine therapy. I'd like to really understand what's happening. So lots of education. We invite therapists. We do talks. We put out information, because it is different. It is different. So there's times at the end of the day, or at times where I have to take a break from it going, oh, wow, this is overwhelming, because I become about this, and I don't want to become about this. I want to, this is my work, but it can't be what I become about. So there's been a real rebalancing of understanding, like, okay, we're doing this work. It's really intense. We really believe in it, but how do we hold that objective perspective as well. How do we know when we're not supposed to do this? Who are the patients for whom this is not a good idea? And being really discerning about that. So there's a lot of discussions, a lot of communication, a lot of teamwork, a lot of consultations. One other thing that I do is be part of a consultation group where I can take my patient stories and be heard by a group of people who are much more experienced, are looking at it through the ethical lens of, there's a wonderful resource called The Ethics of Caring by Kylia Taylor, which is kind of like the gold standard book for any psychedelic healer who's going into this, because the ethics of this is really interesting, situational, challenging, because it is interpersonal. It is in that space where you're in it as much as the patient, and so a greater amount of contact occurs, and so that brings with it some of those stories that you might have heard of, inappropriate conduct. And just this last week, I had a patient who I had done consent with before for a handhold, and within the journey, the patient says, "Oh, can you put your hand on my chest?" And I had to say, while this person was in ketamine and we were still able to talk, and I had to say, "I'm sorry, I can't. But I can, work with you to put your own hand there. I can offer you a cushion that you can hold to give you that pressure. But I did not take consent from you for that before I put you under the medicine, and I can't allow you to change it. And that's on me. That's on me for not having gone through that." And we talked about that. We talked about how that situation actually recreated the situation for this patient, where they were a young part of themselves came out and recognized that I remember what it's like not to be met. I remember what it's like to know I need a hug or know I need comfort and not get it. And we were able to really connect in that level to say that, yeah. And there was anger behind that. There was a discharge there, and I had to really not get involved in the anger. I had to recognize it for what it was, which was a much younger part needing someone else to be there, to be the adult, to resource caring from, and not having had it. So those are some situations where we talk about, closing the loop, having this, we call it, the word is just escaping me, but being, met in that way, completing the trauma cycle, co-regulation, things like that. So yeah, I hope that answered the question, but it's challenging.
It does. So obviously your clinic is a business, and I'm just curious to know what's working particularly well for you as a business, and also similarly, what are some of the challenges and bottlenecks in running the business that you have?
Great question. I think insurance uptake of this business is the biggest, barrier. And it depends on what kind of structure a person, a business wants to have. So clinics that have integration of Spravato, which is the Johnson & Johnson product of the S-ketamine, which ketamine is a racemic product of two isomers. And so the S-ketamine is one isomer, and that has been now, kind of taken up by a lot of psychiatry clinics, where the ketamine is administered as a nasal spray, and the patient is given about 15 minutes of kind of, accompaniment. But and it's taken off. Johnson & Johnson has made upwards of $1 billion on this over the last couple of years. Yeah. So they're not wrong. There's a market for it. However, what we've noticed is that because patients are being left alone in these treatment rooms, they're online. They're on Amazon. They're shopping while they're on ketamine, and they're calling it Ketamine Prime Day. So So let's talk about uptake and safety, right? So insurance is a big challenge. Psychotherapy, the psychotherapy part of it can be reimbursed. However, the ketamine part of it will not. and if you do get reimbursed. So the best place to be reimbursed for it right now in the United States is the VA pipeline. So the Veterans Administration, because it has really run forward with psychedelic treatment, and the VA tends to be ahead in some of these ways because they have such a body of research and such a great populational need that they are actually paying for the treatment. So they'll pay for a bundled treatment, protocol. But our clinic, we have had to be really agile. We've had to think about, okay, patients who come to us, they are usually coming to us. We happen to live in California, which is the fourth largest, economy in the world. So in the world, so it's not like it's a population that's very constrained by, resource. So we do have the people who can afford it, who are coming through and can afford the, $4,000 to $5,000 and the time and the energy and the resources that it would take. So they're not being left out of the psychedelic renaissance. It's the people who are dependent on insurance for their treatment. And so what we are learning is that first initial intense period of 4 to 6 sessions, if we do those through an IV, method with this intensive, kind of protocolized, a lot of support, a lot of integration, a lot of commitment from the patient, we get them to a different baseline. And then it's a matter of keeping them on a maintenance of some sort. And we're finding that maintenance can be once a month, once every 2 weeks, depending on the patient. And so the way my clinic does it is we start everybody off on the IV version, and then we actually transition them to intramuscular, which is easier to administer, a lot less cost and time resource, and you can do it in group settings. So we actually have formulated a way where our patients can engage in the maintenance part using the group therapy model, and that is a lower cost. So we've been able to decrease the cost even more because we're doing a group. So that's one of the things we're seeing also in places like Vancouver. Roots to Thrive is, the kind of gold standard here by Pram Kriskow, who is a physician, also previous firefighter, who's really worked at bringing ketamine-assisted psychotherapy to the insurance system in Canada, and it's being covered there as group therapy. And so really, we're trying to make it work. We're integrating it with other modalities. So sound healing is another modality in which you're really combining psychedelic therapy, especially for somatic, conditions like pain and somatic activation. Those can help. We're combining it with acupuncture, yoga. So we're investigating how to, kind of expand the offerings and how people can, access them. So trying to increase access to it, and using the ketamine as a tool and not the be all and end all. Really, I think my clinic, we've been now in operation for 2.5 years. We were really affected by the fires that occurred in Altadena. That really led to a dampening. There's been a greater diversification of, ketamine providers as well. So I think we're learning from season to season, year to year, that this is a very dynamic space, and we're not at the final, model of it. I think the models are going to evolve based on what it looks like. I think countries like Australia with universal healthcare, where the payment, system is, and the UK where the payer system is much more streamlined. Once you get buy-in, I think those countries will run ahead. And the countries that don't have a good way of paying for it, what will happen is the people who are much more resourced and able to afford it will be able to access it as they are. And then we're going to have to cobble together, there's all these different funds. There's, patient funds. People are coming up with different ideas of how to do it. But I just think, it is a symptom of the overall healthcare here in this country that if you happen to be on insurance, you're probably not going to get access to a lot of these integrative therapies. It's going to be delayed. Yeah.
If I gave you a magic wand and you could fix any one thing in your work, whether it's clinical, operational, educational, what would that be?
Mm. Mm. Nobody's asked me this question. There's so much power in this magic wand. Oh, I think the breaking down of these silos, the breaking down of these informational silos, is critical path, because depending on where you are in the silo and what information you're being fed, you're either very scared of anything to do with psychedelics, or you're all the way out front. And I think that speaks to just how divergent our population has become when it comes to, issues of control and openness, I would say. So I think magic wand, more community, more grassroots involvement, more funding given towards places where people can go to access a whole host of integrative therapies, not just psychedelic therapies, but relational therapy, somatic therapy, acupuncture, nutrition, exercise, just this awareness of how much there's a dearth of it and how access plays into it, and into our general well-being is probably where I'll leave it. But thank you for asking that question.
No worries. And finally, what's next for you in terms of the next 6, 12 months? What are any particular plans or projects or things you're working on or directions you're looking to take?
Absolutely. With IACAP, we're really bringing together the experts in this field to talk more about it, to share their experiences. These are still experiences based in qualitative data. When we put together quantitative, large scale trials, by the time we put together these trials, we've got to know what it is that we're treating. If you have a mixed bag in your quantitative trial, you're going to get mixed results. If we're not discerning as we're going into the trial. So I feel like we're still in the discernment mode. We're still in the mode of, we're still learning. So I really think in this next year, stepping back, bringing this education and awareness through the couple of platforms we have. So we've got a podcast called the Two Curious MDs podcast, where we talk to patients who are going through their healing, as well as practitioners. So we've had really wonderful, it's been a great resource to give to people, to be like, okay, how do you understand what's happening? And really reaching people at where they're at. So are being much, I think, smarter about how we reach out to the pockets of, the populations where we can really have a big bang for our buck. So instead of looking at the psychedelic field as one big thing, we're kind of really focusing down on the populations for whom will move the needle the most and have the best outcomes. And I think whenever you're dealing with something like as complicated as this, maybe that's the best way to do it, is that discernment piece. And personally speaking, I completed the Berkeley psychedelic certification this year. There's been a lot of excitement about doing more group work, especially for healers. So other physicians, there's burnout epidemic in the physician and nursing population and frontline workers, firefighters, police, law enforcement is huge. And this is one of the most, I think, innovative tools that we have to treat a lot of people really quickly. So I think reaching out and encouraging and really mentoring. I think that's the other piece. As we educate, we're educating for professionalization. So mentoring the different people who are coming into this field. I mean, the neuroscientists, there's a slew of research happening in psychedelics. And so there's a great number of young neuroscientists who are coming in, MD, PhDs, who are really curious about how this is working and then the real life experience. So really being a translator, I think, that's where I'm at in the transitions, putting more language to it. I vow to do more writing this year is probably what comes forth.
With that, Suraiya, thank you so much for joining me this afternoon. It's been a really fascinating conversation, such deep insights. Lovely to hear about your journey, great information, great education. And we're not just talking about psychedelics, we've been really talking about rethinking systems around the care of young people, families and healing. So it's been such a fascinating conversation. I'm so grateful that you were able to join me.
Oh, thank you, Andrew. This was wonderful. Thank you for your wonderful questions.